15 days, which was still high, around 6, she says. Uh, Patient noticed bleeding per vaginum on 29th of August 24, for which she was rushed to the obstetrician. She recalls that her ultrasound was done, which was abnormal. After that, the patient spontaneously expelled the products of conception, that she had a spontaneous abortion. She was examined one day after that, and dilatation and curettage was advised, which she underwent on 31st of August 2024. She was discharged one day after that. The patient stopped her medications after this episode. She once again did her 24-hour urine protein, which was also still high, almost uh, like the previous one, around 6, for which she was referred to tertiary care hospital in Delhi for further management. Patient came to the hospital on OPD basis, and she was advised one expensive medicine which she received over 4 to 6 hours. She was also given some medication for to decrease her swelling.
So what do you think was this expensive medicine?
Sir, it was given over 4 to 6 hours, so I think probably it was rituximab.
Probably was rituximab.
Yes. So there was no history of oliguria, no history of polyuria or nocturia, no history of graveluria, no history of passing of cola-colored urine, no history of fatigue, no history of loss of appetite,
So
nights.
if it was rituximab, then what would be the dose that was given, in your opinion?
So it was probably 1 gram.
If you have to give 1 gram of rituximab, what would be the duration? What would be the time frame in which you would want to give it? Hmm? Yeah, you would give it for a longer period of time, not 4 to 6 hours. Isn't it? There is a protocol for giving rituximab in a slow fashion, isn't it? You give first dose as a slow
50
one,
ml
and
per
then you keep on increasing it all
increase.
that. So if 1 gram was to be given, then would it be 4 to 6 hours or it would be longer?
Little longer, sir.
Hmm? Yeah, so she may not have received 1 gram, so she may have received 500
500.
milligrams. So that would probably fit in with 4 to 6 hours. Okay.
So no history of loss of appetite, night sweat or weight loss. No history of rash, joint pains, oral ulcers, hair loss. No history of allergy to any dust or pollens. No history of any alternative medications or painkillers. No history of chest pain,
What kind
palpitation.
of alternative medications would you ask for in this
So,
patient? If you
homeopathic medications, heavy metals.
Which homeopathic medicine causes proteinuria? Is there a name that you would say, or a type of medicine which is known in homeopathy, or you're just saying that alternative medicines, was she taking any alternative medicine? But if there is a specific kind of thing that you would ask,
So heavy metals, any medicines containing heavy metals.
so heavy metals, how would one take heavy metals? Usually heavy metals are used in homeopathy or Ayurveda? Homeopathy or Ayurveda?
Homeopathy.
No. Homeopathy. So थोड़ा सा ऑल्टरनेटिव मेडिसिन के बारे में जानकारी तो पता होनी चाहिए ना कि कौन सी टाइप ऑफ मेडिसिन, isn't it? It's important. General knowledge kind of thing, not necessarily medical, but as a medical person is very important also to say what kind of pathy is being talked about. So when you talk of homeopathy, homeopathy is on the principles of what? How do they get? What's the strength of their extremely dilute? The more dilute their solutions are, the more strength and effective those drugs are. So they dilute their usually. So Ayurveda uses, and if you go to the history of Ayurveda as well, so they used to process these heavy metals by heat, detoxify them. And the reason why these were not toxic at that point of time was because of the detoxification which was essential. But the old Ayurveda physicians would do that for nights together, at night, in their home. and they will detoxify these heavy metals. That's why they were effective at that point. But currently now, the current group of practitioners have given up that. So they don't detoxify them, and therefore use them in basams and other things in Ayurveda, and therefore call. So those are heavy metals. Anything else which is come in vogue, especially when you're looking at a
Skin
nephrotic
lightening
syndrome.
products.
One?
Skin lightening products.
Skin lightening products of these fairness creams. And she's a 22-year-old girl. That's why it becomes very important. So this significant negative history should be not. Are you using any kind of Ayurveda medicines or any alternative medicine? So specifically, because there is a recent sort of evidence which has come forth that these fairness creams have what kind of metal? Mercury. Yeah, and that has been documented from India in many 2-3 studies coming from South. They have documented that you can have what kind of nephropathy one is looking at, and any specific L1 associated. Yeah, so that's the one. So in history, it becomes important to go specifically into that kind of. Although you don't know yet whether this is membranous or not, but since this is a young girl with 22 years, so has nephrotic syndrome, and therefore it would be important to look at that kind of history. So heavy metals would be important. Yes, is she taking any kind of for whatever purpose, or fairness creams would be very, very important in this. Okay, so be specific whenever you are taking a history. If you have a clinical spectrum of nephrotic syndrome, then be specific to these are the things. There's no point in giving this didn't happen, this didn't happen, this didn't happen. So give very specific. Then a person knows, the examiner knows that here is this person who is aware of what is happening. Okay? Okay, go ahead.
Sir, past history. No history of any illness in the childhood, no history of hypertension, type 1 diabetes, hypothyroid, or tuberculosis in the past. Family history, no history of any illness in the family. Obstetric history, patient was married 1 year back. It was a non-consanguineous marriage with her last menstrual period being 10th of March 2024. ANC history, patient was a registered case. Her scan was done for confirmation. She was started on iron and folic acid tablets. Patient also received one tetanus toxoid dose at 16 weeks. Personal history.
She received what?
Tetanus toxoid dose in pregnancy. Personal history, normal bowel and bladder habits, mixed diet, no addiction, and Kuppuswami, upper middle class.
To summarize?
22-year-old female detected pregnancy on 15th of April 2024, presented with urinary tract infection for which she was treated at 9 weeks of gestation. Along with that, she detected as nephrotic range proteinuria done on a 24-hour urine sample. At period of gestation of 11 weeks, patient had complaint of bilateral lower limb edema, frothuria, for which she was referred to nephrologist. Underwent renal biopsy on 31st of July 24. Patient had spontaneous abortion on 29th of August 24 and dilatation in curettage done on 31st of August 24, and came to a tertiary care hospital in Delhi and received one expensive injection.
Anyone has any other history that one would want to ask from this patient, or whatever history you feel? Anything else? Nothing. So, if you were to look at this from a clinical perspective, then what are the thoughts that are coming to you? Likely possibilities.
Sir, diagnosis?
No, differential. अभी diagnosis तो physical examination भी नहीं किया तो फिर diagnosis कहाँ? So you will give a differential things which come to your mind. You said that this looks like a nephrotic syndrome, which is you gave a figure of 7 grams or so, which she told you that she's got 7 grams of proteinuria. So obviously she has edema, proteinuria of this sort, and so she has nephrotic syndrome. So what do you think would be the causes of nephrotic syndrome in this 22-year-old female? Also, so what would be the causes? 1, 2, 3. Just a general random one.
Minimal change disease can be.
So minimal change disease, okay. Minimal
Second can be,
change.
sir, focal segmental glomerulosclerosis.
It could be a focal segmental glomerulosclerosis.
Third, sir, membranous nephropathy.
Membranous nephropathy. Okay. So primary nephrotic syndrome, which could be MCD, FHGS, and membranous. Anyone which you will say would be higher than the other, or you think you will favor MCD, FHGS, or membranous, or you will say anything?
First MCD, second FHGS, third membranous, probably.
For any specific reason, or just because you like it in that order? Any reason why you say MCD?
So she does not have hypertension or renal derangement. So almost up to 10%, less than 10% of cases of MCD can have hypertension. So FHGS, it will be around 30 to 50% can have hypertension, and renal derangement will be also present in 20 to 40% patients. So that's why little higher than FHGS. But still age, if we go by the age, FHGS is more common in this age, between 18 to 40 years. And so primary membranous can also present, or it can also, sir, as she is a female of 22-year-old, I would also like to rule out lupus.
Yeah, so secondary. So I think the secondary nephrotic syndrome could be a lupus nephritis. It presents during pregnancy, early
flare-ups,
early pregnancy. So lupus would be another consideration that you would. Anything else?
Lower down the order with C3GN.
Why would you think of C3GN?
It can also present as a nephrotic syndrome.
Nephrotic syndrome के हजारों कारण हो सकते हैं, but when you think of causes, then there must be a reason to think of those causes. No? It could be multiple myeloma, it could be anything. If you had UTI, doesn't do it. So many things can occur, but a specific reason for lupus looks reasonable, but why C3? Because that's what you read recently, or how many cases C3GN you see? कितने देखे? बहुत सारे देखे? नहीं देखे. Common? Very common? No. So give diagnosis which is sort of a reasonable kind of a thing. So at the moment we're not picking. We just randomly thinking that whenever you are taking a history, you should, something will come into your mind that maybe this is membranous, maybe this is minimal change, maybe FHGS. These are common causes of nephrotic syndrome at this age group. So one of these three probably looks to be okay. And then a lupus would be definitely another consideration in this kind of a situation. So that's okay. So anything else anyone else would want to think about, rule out or so? IgA nephropathy. So common presentations, nephrotic syndrome as a presentation of IgA nephropathy, how common? 5%. Yeah, less than 5%. So less than 5% presenting as IgA. So would be odd. I would be surprised if it turns out. It can turn out. Anything can come out. But would not be my priority diagnosis at this point of time, because nephrotic syndrome as a presentation for IgA nephropathy is less than 5%. So not a common diagnosis. Okay. Let's go for physical examination.
General examination. Patient is conscious, oriented to time, place, and person. BMI of around 31. She is afebrile. Pulse of 83 per minute, regular, normal volume. Condition of vessel walls normal. All peripheral pulsations well fed. No radial or radiofemoral delay. Blood pressure is 120 by 80 mm of Hg in right arm supine position. Equal in all four limbs. Her JVP is not raised. Edema feet present up to knee bilaterally, pitting type. No clubbing, no lymphadenopathy. The hairs are normal, nails normal, no rash, no joint tenderness or redness, no oral ulcers, ear and nose examination normal, and no xanthelasmas.
लूपस के लिए कोई खास oral ulcers you talked
Oral
about?
ulcers were not
Skin?
there, no rash was there,
Okay,
no any joint tenderness or redness was there.
okay. She is a Kashmiri, fair, must be a fair
Yes,
lady,
sir.
so you could see lupoid facies or something like that, or no? There wasn't.
There wasn't,
There
sir.
wasn't. So specifically, you should mention some of the things because that's your one of the differential diagnosis itself. So you should, in your physical examination, look at whatever you thought of as a differential diagnosis. So to tell the examiner that I've looked for this as a, so it should automatically. So he doesn't have to ask you a question on that. Okay. Yes.
Systemic is
Go ahead. But anything changed from the diagnosis? You still on the same
on same, sir.
same diagnosis. Okay. So you think it is MCD, FHGS, membranous. Anything in the physical examination which tells you that one may be more likely than the other? Nothing.
Sir,
Yeah, you don't have to necessarily. See, this will be one of your exam case. Definitely. Everybody is going to have one nephrotic syndrome as a presentation. And this would be a common kind of a thing. Is it minimal change disease? Is it FHGS? Is it membranous? And you will have relative points of this. Age being in this favor, membranous occurs in 20 to 40 years of age, maybe. Elderly people and not minimal change, maybe in younger people. FHGS and young adolescent and young adults, that those kind of relative counter, but they can occur in any age group. You can have a minimal change disease in a 60-year-old person, and you can have a membranous nephropathy in a 20-year-old girl. So same way, FHGS can occur in younger people, adults, as well as so. So there isn't a definitive kind of a marker or a characteristic, clinical characteristic, which will distinguish or tell you that this is the patient who's got minimal change disease. So on clinical examination, by and large, your point should be that maybe this looks like this, and if there is a younger person, if there was a 7-year-old kid, then obviously minimal change disease would be something which would be commoner. But if there's somebody membranous 70-year-old person with nephrotic syndrome, then either amyloid or membranous nephropathy would be more likely. So those are characteristics. But by and large, you will think that it could be minimal change FHGS. And in the exam, don't hesitate to say that it is difficult to pinpoint whether this is going to be. And I wouldn't be surprised if it turns out to be a membranous. It could be focal segmental. If we knew clinically, then we wouldn't do a biopsy. Why would we do a biopsy? The reason. So even the examiner knows that is difficult, and clinically he or she also has no clues, and it may turn out to be minimal change or a focal segmental sclerosis. So in the exam also you should give general points in favor or against, but in the end you can say that it's difficult to pinpoint whether this is minimal change disease or focal segmental sclerosis or glom or a membranous nephropathy also. And I wouldn't be surprised if it turns out to be a membranous nephropathy. Unless you're reasonably, there's everything else. There is renal dysfunction and there is some amount of uh, past history of, say, vesico-ureteric reflux or recurrent urinary tract infection, it's a secondary FHGS and not. So then your diagnosis will become into a particular kind of a fashion. But otherwise, you could, in the exam, also keep on saying that. So this is what I would feel. These are three possibilities, and any one of these, and we'll have to do a biopsy to do this. So don't hesitate to sort of be clear cut on it. And if the examiner pushes you to say that, he says it's difficult, it's not going to be easy. That's why we do a biopsy. You can tell him, remind him that that's why we do some biopsy. If I knew or if you were knowing it, you wouldn't do a biopsy, then we would. So you can just be gentle and remind that's what it is. So there isn't any harm in doing this after you've given a reasonable explanation of the prevalence in a particular age group and some of the characteristics which you talked about. So that's okay. So your diagnosis at the moment remains the same. It hasn't changed. Okay. So nephrotic syndrome is what? How do you define nephrotic syndrome?
So nephrotic syndrome is defined as urine protein, 24-hour urine protein excretion more than 3.5 gram in a day, along with edema, hypoalbuminemia, and dyslipidemia.
Okay. And nephrotic syndrome?
So nephrotic syndrome is a constellation of findings suggestive of oliguria, hypertension, colloquial urine or hematuria, edema.
So, if you have a patient who has oliguria and has proteinuria, so this patient develops oliguria and there is mild hypertension. So, would you consider this as nephrotic syndrome or would you consider this as nephrotic syndrome? So, can oliguria occur in nephrotic syndrome?
Yes, sir. AKI can occur in nephrotic syndrome.
Is oliguria always suggestive of AKI or you can have oliguria in nephrotic syndrome as such also? Do they become hypovolemic or not?
Yes, sir.
Are they hypovolemic, hypervolemic? Hypervolemic. So, and so they are hypervolemic and intravascular volume would be decreased, and that's because of the low albumin that occurs. Why is there hypoalbuminemia in these people? Nephrotic syndrome, why is there hypoalbuminemia? Why is there? Saying I'm asking a stupid question. If they are passing albumin in the urine, they should get hypoalbuminemia. Pardon?
Blunted hepatic compensation.
Yeah. So ordinarily, if you have low albumins, liver starts manufacturing large amounts of albumin, and it should compensate for that. But it is not able to compensate for this. Anything else? And edema in this occurs because of? Why is there edema in nephrotic syndrome?
Both overfill and underfill theory.
But what's the reason of this? What the theory of it? What's the reason for edema?
Decrease in oncotic pressure
Decrease in oncotic pressure causes what?
and increase in hydrostatic pressure leads to extravasation of fluid from intravascular compartment to extravascular compartment.
Any other?
So hypoalbuminemia and sodium retention.
So there is increased sodium retention. So intravascular volume leads to increase in sodium reabsorption. So proximal tubule gets the feel that there is low filling in the intravascular compartment, which is your underfill or the overfill theory. So underfill theory that your intravascular volume goes and salt retention occurs. Anything else? Do you think that salt retention in nephrotic syndrome could be the primary defect? Anyone says why there increased salt absorption in nephrotic syndrome? In addition to the hypovolemia, intravascular volume being low and greater sodium reabsorption, but anything else? One? Inactive channel is activated because of what? Pardon?
Plasminogen converting to plasmin and it's activating in channel.
Yeah, so because there is increased permeability and therefore you have these plasminogen emitters, so plasminogen gets activated because of inhibition of the inhibitor. So that it is the activation of plasmin which causes NAC activation and all that. So sodium is a predominant reason for getting edema in these patients. So there is increased sodium reabsorption in patients with nephrotic syndrome. So if you have proteinuria of 7 grams, 2 eggs should take care of this, isn't it? 2 eggs, 10 grams of protein, you give 2 grams of 2 eggs every day to this patient. Why should they get worried about proteinuria? Why is it that it doesn't make them better? Have you asked this question? 7 grams of protein, 2 eggs gives them 10 grams, so 3 grams extra. But it doesn't make them better. Why not? You give them 4 eggs, it doesn't still make them better. You give them 6 eggs, it doesn't still make them better. Anyone else? Why would? Pardon? Malabsorption in the gut. They don't absorb protein that much because of the edema in the gut. I don't think that's the explanation. How much is the protein loss in patients with nephrotic syndrome? How much is the protein loss in nephrotic syndrome? Is it 7 grams or is more?
It's more. We measure it 7 grams, but protein is losing more.
So what happens? Where is this protein gone? You say that there is protein increase, protein loss, which is more than the 7 grams protein. I agree with you. But where is that protein gone? Where is that protein? So when the glomerular filter opens up, so large amounts of protein get filtered. Normally there isn't much of albumin which goes into the tubule, isn't it? Very little of it goes into the tubule, small amounts. But when glomerular filter opens up and there is increased permeability of the glomerulus, that's what the primary fault is in the nephrotic syndrome. So what happens? Large amounts of albumin and other proteins also will go inside. So what happens to this protein which is filtered? So it's not only 7 grams which is filtered. Very large amounts of protein will get filtered, probably. Isn't it?
Catabolism.
So it is reabsorbed back into the tubules and catabolized there. So large amounts of proteins are catabolized there. So how will you know how much of protein is catabolized? पढ़ा आपने कुछ? How will you know how much of protein is catabolized? You measured 7 grams, which is excreted. But how will you know how much of protein is catabolized? How much protein was filtered and which was catabolized? Can you find out? Anyone? Anyone? Third year? Monica ji? What? How much of protein will be catabolized? How would you know how much of protein is catabolized? अरे भाई प्रोटीन जब कैटाबलाइज होता है तो क्या होता है? What happens? अरे भाई फर्स्ट ईयर सेकेंड ईयर में पढ़ा आपने बायोकेमिस्ट्री क्लासेस में प्रोटीन डिग्रेडेशन से क्या बनता है? यूरिया नाइट्रोजन भाई क्रेब्स साइकिल. So urea nitrogen. So, and what happens to urea nitrogen? It is increased, but how will you know that how much of urea nitrogen is generated? Hey, bhai, it is excreted. What happens to urea nitrogen in the body? Liver, through the Krebs cycle, urea nitrogen is excreted by the kidney. So if you measure 24 hours urine nitrogen or urea nitrogen, you will know how much of protein. How will you know from nitrogen how much protein is catabolized? How much? How will you know from? So if you have 4 grams of urea nitrogen, so how much of protein is catabolized? है भाई कैसे पढ़ाई करते हो भाई? तो नेफ्रोटिक सिंड्रोम तो फंडामेंटल नेफ्रोलॉजी है भाई. तो हर एक को आना है ये केस. आई एम टेलिंग यू एवरी वन ऑफ यू विल हैव वन ऑफ योर केसेस विल बी नेफ्रोटिक सिंड्रोम. So you have to be good at knowing what nephrotic syndrome is. In addition to knowing the differential diagnosis, but also how would you manage these patients and how to. percentage of protein to nitrogen conversion क्या है? 16%, isn't it? So 6.25 is the multiplication factor. 100 grams of protein will generate something like 6. So 16% utilization. So you will multiply 4 grams by 6.25 because 100 divided by 16% will be 96.25. So that will make it 100. So 6.25. So multiply 4 grams by 6.25. That will tell you how much is the amount of protein which has been catabolized. Isn't it? So that is how you will know that is the amount of protein which is catabolized. And keeping these people in nutritional states and all that, so you will require those kind of protein diets and all that. So that's why, since protein intake in our patients is extremely low, as such also Indians by and large are low in protein, so therefore it becomes difficult to maintain them into that. So therefore they become hypoproteinemic and hypoalbuminemic. They're not able to maintain this because we will never be able to match that kind of protein intake as such. So they become hypoproteinemic, and hypoproteinemia and hypoalbuminemia leads to, and because of hypovolemia as such, increased sodium absorption, and because of the plasmin and others, there is increased sodium reabsorption, ENaC and all that. So salt and water overload occurs. Now, when will oliguria occur in a patient with? One is, you said that acute tubular necrosis or acute. Which are the patients where it will happen more often? Which patients will develop acute kidney injury in nephrotic syndrome? So minimal change. It occurs much more in what? Which kind type? If we had a patient, if he had acute kidney injury and the creatinine was 6 and you thought that this was acute kidney injury. So out of these diagnoses, which one would be the one which you will think will happen?
MCD.
Yeah, it happens much more in minimal change disease. It happens very, very correctly. Which are the kinds of patients where it happens? Young children. It can happen in young children or an elderly population. So that's where it happens much more frequently because they are the ones where volume, and they can get severe volume. And then you give a diuretic along with, they come further aggravated and they can develop an acute hypovolemic acute tubular injury and acute kidney injury. It will recover overall as you start diuresing these patients slowly and steadily. So that can, and it will favor minimal change disease. That occurs much more frequently in minimal change disease than in FHGS. So acute kidney injury can occur in these. But when acute kidney injury occurs, say if you were to distinguish whether this patient has, the patients are not very clear. They get swelling, they have it. Also oliguria, and they may have been, you're not very sure which came first. Was it oliguria or was it minimal change? So in nephritic and nephrotic syndrome with oliguria, how would you differentiate? Is it nephritic or is it nephrotic?
So
Anyone?
nephritic will be abrupt onset.
Oliguria, yeah, one is abrupt onset, okay. So that's true, is an abrupt onset. It's an acute condition. So abrupt onset, okay. But many times patients are not very clear. They wake up all of a sudden and they find that there is some swelling over their eyes, there is swelling over feet, and they also start passing less urine. So would this be nephritic or this would be nephrotic?
Hypertension or cola colored urine.
Yeah, they may give you, every symptom may not be present. So they may give you this history, may not give you. So oliguria is a presenting feature of nephrotic syndrome. It will present first. Oliguria in nephrotic syndrome will occur when they become hypovolemic and all that. So once they become edematous and all that, so it will be of some duration before they become. They become oliguric only when they have severe hypovolemia. And for them to become severely hypovolemic, they will have to have lot of edema and all that. So when you have oliguria in acute nephritic syndrome, that's a presenting symptom. Oliguria is a presenting symptom. Usually oliguria, hematuria, and then edema occurs. Edema is secondary to retention of salt and water because of oliguria. isn't it? There isn't great membrane permeability, increase in membrane permeability, mild increase in glomerular disease occur. So mild permeability, but salt and water retention, acute deterioration in kidney function, GFR declines, creatinine goes up, and hypertension occurs. Salt and water retention. Hypertension is not a feature of that of a nephrotic syndrome, and that's basically because they become hypovolemic. And hypervolemia is a feature of acute nephrotic syndrome. They are volume overloaded. Therefore, hypertension is because of salt and water. So this is very important to understand these on clinical grounds. So the pathophysiology has to be very, very clear in your mind that acute nephrotic syndrome is a condition where there is oliguria, there is hematuria, there is retention of salt and water, hypertension, and then in nephrotic syndrome, predominantly proteinuria, okay, and edema, and then oliguria can occur as a late. Hypertension can be again different features but by and large these people are not salt and water overloaded because they become hypovolemic, at least in the intravascular volume there. Whereas the intravascular volume in nephritic syndrome is high. So pathophysiologically, you should be clear in your mind that these are two different conditions that one is talking about. But this can come in a differential diagnosis on clinical ground. And this is where the examiners will fault you. You don't tell them MCD, FAGS or something, whether you have 1 or 2. I don't care. I don't think I will fail you on that. But if you didn't understand this difference, then I'll fail it because physiologically you not understood the difference between an acute nephritic syndrome. And therefore, reading general nephrology, Harrison's first 70 pages, very important. That's where you will understand this. So reading general features of this will not be, these are various syndromes of, there are books which have written these clinical features of a kidney disease also, different forms of kidney diseases and all, where you have nephritic syndrome, nephrotic syndrome, hypertension, chronic kidney disease and all. So these are very, very important to understand the differences. As a nephrologist, this is where you should be able to tell whether this is nephritic, nephrotic, or it could be a combination of nephritic, nephrotic, which are conditions where different things like C3GN. If it was nephritic, nephrotic, that's where I would think of C3GN, which is proteinuria associated with renal dysfunction. That's where I would think of. MPGN would be a kind of a differential diagnosis in those. And those, then various causes of MPGN. So that's where one would think this would be. So moving further, so the background of proteinuria and the amount of protein and how do you calculate and how will you know protein nutritional assessment and how much of protein needs to be given. Some of the examiners could ask you these questions, and it's good to know this background of physiology which you read in first year, second year of your MBBS, and then knitting it all together when you are now doing your DNB. So it's important to knit that background information of urea kinetics and protein and nutritional assessment in a patient with nephrotic syndrome. That becomes important, and it's important also for chronic kidney disease, nutritional assessment and all that. So all this would be important for that purposes. How to know how much of is the urea clearances, creatinine clearances and all that, how much protein is lost, and all those would be important. So moving further, what would you do now? So you know that you have a patient with nephrotic syndrome, 22-year-old who had pregnancy and lupus. Now in pregnancy, suppose she was to continue this pregnancy or she didn't abort. So are there different challenges of managing patients with nephrotic syndrome in pregnancy, or you think they are as good as non-pregnant patients?
So immunosuppressions have to be given according to the pregnancy. Like, and certain diuretics we cannot give in pregnancy except if the patient is in severe pulmonary edema, because they can lead to intravascular volume depletion and cause uteroplacental insufficiency. So ACE inhibitor ARB cannot be given in second and third trimester, as they can cause oligohydramnios or pulmonary dysplasia. or limb defects, sir.
Mm-hmm.
And sir, anticoagulation has to be given in nephrotic syndrome in pregnancy if the serum albumin is less than 2.5 and the proteinuria is more than 3.5. We'll have to consider heparin.
You think pregnancy would make outcomes of pregnancy would be different in these patients, or kidney disease can have any
Sir,
different?
there are more chances of preeclampsia, preterm birth, intrauterine growth retardation, um, spontaneous abortions.
Suppose the kidney function as was here was normal.
Yes, sir. It
So
here
kidney function is normal. So even then you are concerned, or you're not concerned, or you're still concerned
still concerned.
because of what?
As it is a
So
proton.
kidney function is important or not important for outcomes of pregnancy? So kidney function is normal. So only an abnormal kidney function will have a poorer outcome. So protein, what's the impact of proteinuria on the outcomes of pregnancy? So these would be the questions which, since pregnancy comes into this history, the examiners can divert into pregnancy and kidney disease. So this is an occasion for patients, for examiners to know how much you know about pregnancy. So this would be the direction in which it could go. So you should be based on the kind of history that you present. So you should also be ready with some answers in your mind that these are the likely questions which are going to be asked also, because now you know that there is a patient who has had pregnancy, although she spontaneously aborted, but the examiner might ask you questions related to pregnancy. So kidney function, normal kidney function, good outcomes or poor outcomes. In pregnancy, normal, if kidney function was to be isolated, normal kidney function, good outcomes, poor outcomes. Good outcomes in comparison to somebody who's got creatinine is more than 2, 1.52, considered to be having poorer outcomes, both in terms of successful pregnancies as well as other complications. Proteinuria,
Poor outcome.
in terms of
So increased risk of.
one is morbidity. Comorbidities might increase. The edema and managing these patients with proteinuria and might increase. And then you have other fetal complications which can occur. Fetal growth retardation and all that will be there, and prematurity will be there. And then there could be preeclampsia and all that would be, because there may be an underlying cause for the disease. Hypertension. Many of these patients develop hypertension. So how would you know whether there is, in renal disease, how do patients present in pregnancy? If they become pregnant, what will happen?
So chances of going into ESRD are high. According to
No,
stages.
what happens to pregnancy? What happens to pregnancy? First trimester, second trimester, third trimester.
In first trimester, increased renal plasma flow is there, increased GFR is there, the dilatation of the calyces is there,
It
physiological.
happens in first trimester, increase in GFR.
From second on.
Yeah, second trimester onwards, not first trimester. Usually first trimester the GFR may not be high, but second trimester onwards the GFR goes, in normal pregnancy, the GFR goes up, and by what percentage?
So GFR by 50%.
Yeah, by about 30 to 50%. Plasma flow goes up.
80%.
And, yeah, goes up. And then what happens to blood pressure? Blood pressure,
Rise.
second trimester, drops. So blood pressure drops. Usually there is lower blood pressures in the second trimester, and then the blood pressures tend to come back to normal levels in the third trimester. So preeclampsia is a disease which occurs in which trimester?
After 20 weeks, second trimester.
And in patients with kidney disease? When can preeclampsia occur? Preeclampsia in kidney disease can occur in the first trimester itself. So you may have features of preeclampsia in the first trimester. So it gets very difficult to distinguish whether there is preeclampsia which has occurred in the first trimester or there is an underlying kidney disease in this. Isn't it? So it gets difficult to sort of measure. So patients. What are the other causes of preeclampsia in first trimester itself or second trimester? One is kidney disease. Anyone else? Hypertension. What else? What? Anyone better? Multiple pregnancies?
So primigravida.
Right? Primigravida, not primigravida. Preeclampsia occurs in the third trimester. That's where it occurs. That's where the diagnosis.
When SLE is applied, can occur.
Yeah, that's kidney disease. All of them do it through kidney disease. Anything else? A gynecological condition or a obstetric condition? Late हो गया. I'm forgetting the name. This is ये chorionic molar pregnancy. Molar pregnancy. So that's where it occurs. So molar pregnancy and multiple pregnancies. And
IVF also is there.
But
IVF, they have said that.
IVF is where they have these multiple pregnancies and all through that happens commonly. Okay. So pregnancy can be a differential diagnosis in your exam. If pregnancy comes, then be ready with that. Okay. So how will you proceed further in this patient now?
Sir, I will.
So you will. She's already had a biopsy, isn't it?
Yes.
So what is the biopsy finding? Would you like to know anything else? Obviously, she's had a biopsy. She would have had an ultrasound. 24 hours urine protein we know was nephrotic. Then there is no RBCs in the urine.
No, sir.
No RBCs in the urine. Okay. So that would be important, especially in terms that your differential diagnosis is lupus, and then even in membranous or FSGS, if there are microscopic hematuria, that would be much more in favor of FSGS or membranous nephropathy. Minimal change disease, microscopic hematuria is less than 20%. Less than 20%. So microscopic hematuria can occur in about 20%, but so usually less than 20%. Okay. So no microscopic hematuria. Okay.
So biopsy report. Microscopy. Multiple sections stained with HNE pass. Silver methylene congruent include renal cortical parenchymal area. 14 glomes, 2 globally sclerosed. The remaining glomeruli reveal diffuse thickening of capillaries, which reveal intramembranous mottling in silver methanamine stained sections. One glomerulus shows segmented tuft sclerosis, and few glomeruli show segmental subendothelial deposit. There is no evidence of tuft necrosis, congophilic deposits, endocapillary hypercellularity, intracapillary thrombi, or crescent formation in the visualized glomeruli. Tubular atrophy and interstitial fibrosis involve less than 10% of sample cortex. Tubules show cytoplasmic vacuolar change, few hyaline and granular cast in tubular lumina, and focal mild chronic interstitial inflammation. Arteries and arterioles are unremarkable. Immunofluorescence, IgA 1 plus in capillary wall and segmental mesangial granular, IgG 3 plus capillary wall, IgM 2 plus, C3 1 plus, C1q 1/2, kappa light chains 3 plus, lambda light chains 3 plus. IHC staining for antiplatoire, thrombospondin 7Da, NEL1, exhaustion 1, and semaphorin 3b is negative. And sir, electron microscopy. The glomerular basement membrane are diffusely thickened. Diffuse effacement of food process and of visceral epithelial cells is noted. Several intramembranous and few subepithelial electron-dense deposits are identified, which do not show definitive substructure on examination at high magnification. Few subendothelial and mesangial electron-dense deposits are also noted. Tubular reticular inclusions are not identified. and focal microvillus change of terminal process of visceral epithelial cell is noted. So impression, intramembranous subepithelial fuse, subendothelial and mesangial electron dense deposit. No structure is identified in deposits. Thickened glomerular basement membrane and diffuse widespread effacement of visceral epithelial food processes.
So diagnosis is?
So secondary membranous.
So what would be the secondary membranes?
So lupus first possibility. Though the markers are negative, but still, sir, it can be the presentation of lupus can
Yeah.
still be.
So ANA was negative.
ANA was negative.
Anti-dsDNA
Negative.
negative. Okay. And C3, C4
Were normal.
are normal. Okay. And
Serum plateau was also negative.
yeah, Plat2 was negative. Okay. And on staining, there isn't any antigen which is being. So the primary membranous nephropathy is out. And the immunofluorescence shows almost a full house. So a full house immunofluorescence with C1q, which is again characteristic. So it is important, especially for making a diagnosis of lupus. If you have C1q, it tells you about the classical pathway, which is important in lupus. So this is looks like a lupus nephritis, but without lupus. So lupus nephritis sans lupus. There is no clinical history suggested except that she is a young girl. So is it possible that she has lupus? What percentage of people will have this kind of?
20 to 30% of lupus nephritis.
Have means they will have anti-dsDNA negative, ANA negative, C3, C4 is 30%. Yeah, 4%. So only 4% people with lupus nephritis or with lupus itself will have dsDNA or no evidence, clinical evidence of a lupus at all. Isn't it? There isn't anything. He didn't tell us anything in the clinical history except that she was a young female and had nephrotic syndrome. So secondary lupus does get into the picture. So lupus was there in your picture, but at least clinically there wasn't anything which would suggest that this is lupus. But that's the reason why we said that we would do a biopsy in such a patient, because clinically she fitted in more with a primary kind of nephrotic syndrome, but it turns out to be a secondary nephrotic syndrome. But there is no feature of. And John Stuart Cameron, who was the president of the International Society and the chief of nephrology at the Guy's Hospital, wrote an article, Lupus Nephritis sans lupus. So without lupus nephritis. And these are patients who will present like a lupus nephritis patient, but there isn't any other evidence of lupus at all. And 3 years later, they can present with the clinical features of lupus and all that. So he has described a series of people who, you can go back, I think this is an article somewhere about 20-25 years earlier. You will find Stuart Cameron describing lupus nephritis with lupus. And this has been, lupus is one disease which will have multiple protein manifestations. So there will be somebody who may present with hematological presentation, no other features of lupus, just hematology. Somebody who presents with renal features, like this patient, on histology turns out to be a lupus nephritis-like picture, and nothing else as such, and many years later presents with hematological or other features of lupus as such, secondary lupus and other things. So these are known. Is it that anyone know about genetics of lupus and all that? Not read. I don't think you would have gone and read about. What are the animal models for lupus nephritis? Third year residents should know this. Right. I think it's good because sometimes this is, you will not fail if you didn't know this. That's true. And since your primary sort of aim is to pass your exam first, but I think in life it's important always to also sort of look at the world in the bigger canvas, a larger picture of how do these. And animal experiments have, especially animal models, have provided extremely good understanding of the immune mechanisms of these diseases and how they can be developed and what are the various differences. So animal models can become very good. Membranous animal model?
Human nephritis.
Hayman's nephritis. So how is it produced? Which is the antigen?
Magellan.
Magellan. So what's the problem with Magellan? And why is Hayman's nephritis not applicable to humans? Magellan is not found in humans. There is no Magellan in humans. So you don't have Magellan in the human. So that's why there is this problem with. Although otherwise, Hayman's nephritis explains everything about membranous nephropathy. But unfortunately, there is no Magellan in humans. So it's been lost with the way we have evolved, and we've lost Magellan. So Magellan is not. So animal models will explain, and so it's good to read about animal models and all that, and various genes which can be, various complement factors which can be, complement deficiencies, making lupus nephritis much more commoner in certain individuals who have specific complement deficiencies. So lupus presents in them. So it would be good to look at some of those also in whenever you have a patient who presents with these kind of things. You don't have anything else to look at, but you no clinical features, but lupus nephritis. So how will you treat it?
So class 5 lupus.
So you will treat it with class 5 lupus, which is, so what's the treatment for class 5 lupus?
So, oral steroids plus tablet MMF. We can one regimen is done.
So you could treat them.
Yes, just she is a young female endoxin. We'll treat with Visolin and MMF, sir.
So with Visolin, so steroids and MMF would be your drug of choice for lupus. Were you there yesterday in the regain, or how many of you attended regain yesterday? You attended regain. So there was discussion on management of lupus as such. So that's why I thought that it would be. So you would agree with him that you would treat with. How will you treat?
Steroids plus CNI.
Steroids plus CNIs. Okay. Any specific reason?
Class 5 with nephrotic syndrome, so CNIs would be better for proteinuria.
For proteinuria, yeah. For reduction in proteinuria, if proteinuria is the thing, patient with nephrotic syndrome, edema, and also you might have a better response with steroids with cyclosporin. Cyclosporin or tacrolimus or voclosporin?
Voclosporin is
Not available with us. So, but there is data on voclosporin in patients with lupus nephritis, and so although they were not pure membranous nephropathy, but they were people with class 3, 4, 5 with membranous. So mixed people who were voclosporin were shown to be effective. So you could choose any of these. Unfortunately, this is one subclass of lupus where we don't have good evidence. You don't have a pure membranous lupus nephritis. Usually, you have patients who have been included in the trials are people with who have class 3, 4 lupus, along with maybe some membranous. So pure membranous lupus is not being included in large trials. So you don't have very good evidence to show that these classes of drugs are very effective in these. So by and large, the response is not as good as you see in class 3 or 4 in lupus membranous nephropathy. So you could use any of these combinations. Obviously, in a 22-year-old, you are concerned about cyclophosphamide as a primary drug. So you could use either mycophenolate mofetil, or if there is a lot of edema and is not getting better, then probably a calcineurin inhibitor would be a reasonable choice, and tacrolimus for a young girl would be much better than cyclosporin because of the hair and other cosmetic reasons. So therefore, tacrolimus would be a good use in that patient. So you would use probably. How long would you continue the treatment?
Around 24 to 36 months.
24. What will you do after 24 to 36? What happens to these lesions in 24? If you were to rebiopsy, what will happen to these? Difficult question. You wouldn't have seen such a thing. So Dr. Kullar yesterday did talk about doing a repeat biopsy in patients. And when would you repeat a biopsy in a patient with lupus nephritis?
Proteinuria.
Pardon? So patient has responded, your proteinuria has gone down, she is doing well. So you keep on tapering the doses of immunosuppression. Steroids would stop at some point of time. These days you use higher dose steroids or low dose steroids?
Lower dose.
So these days there is evidence for a lower dose steroid. So you don't use the kind of steroids we were using in early days. You start with something like 40 milligrams of prednisolone itself would be good enough, and then you quickly taper. The general guideline these days is for a quicker taper of steroids rather than and maintaining them at about 5 to 10 milligrams of steroids along with other immunosuppressive drugs. And mycophenolate mofetil or a calcineurin inhibitor would be good. Uh, if she was to be given, if she doesn't respond to this in 6 months' time, so you will use then what? Cyclophosphamide? So what are the challenges of cyclophosphamide? If you were to use cyclophosphamide, suppose she was class 4 lupus, with renal dysfunction, you have no choice but to use cyclophosphamide. So what are the challenges you will have in a 22-year-old person with cyclophosphamide?
Infertility is because of young.
What is the dose at which infertility?
10 grams.
10 grams. Where infertility may occur. And what's the dose you will use in lupus nephritis cyclophosphamide? What regime? What regime?
Urolupus regime.
Urolupus. So urolupus uses what?
IV
Cyclophosphamide for how long? 6 months.
500 milligram, 500 mg every 15 days for 3
So
months.
3 months. So what will happen after that? Then you will, if they go into remission, then you maintain them. Maintain them with what?
So MMF or azathioprine.
MMF. What's your favorite?
MMF.
MMF. Why? Why not ESA? So why not ESA? Why mycophenolate? Which trial showed superiority of?
Aspirova lupus management.
So that trial showed superiority of MFO4 maintenance phase, azathioprine. But azathioprine can be a good drug to maintain also in many of these patients. So especially good for young girls who are in remission. You are on a long term. She wants to get pregnant. She's lost one pregnancy, and therefore they would want to go. So azathioprine has a very strong favorable effect during pregnancy and all that. With MMF, you will have to again remove mycophenolate mofetil and all that. So azathioprine could be a good maintenance drug in a young girl like her. And if you was to use cyclophosphamide, what are the one is that you will not go to 9 grams. So you could use it or not. You're still concerned.
Still concerned.
Why? Why are you still concerned? There is no good evidence to show that 3 grams causes. You're going to use 3 grams, isn't it? So why are you concerned? See, severe lupus, the best evidence for lupus nephritis is with cyclophosphamide, especially for severe lupus. Even the guidelines say that this is so. Okay. So you should not be concerned. At this point of time, it's important to achieve remission. So many times, this will happen many times in your lifetime. That you will have two contrasting things, a relative contraindication to use this drug in a young person. And you will be fraught with now taking a clinical decision, should you use this or not. And you're not sure yourself, what would you do? So, and there are no books which will tell you this. She will have to make it. And she is dependent on you because she feels that you are the most knowledgeable person around. So you will have to take these decisions. So in life, whatever is good to produce that remission. At that point of time, it's important to produce remission in that. And if you have to use, what are the other things that you will do while using cyclophosphamide in a young girl who also has a concern that हो सकता he is newly married, the husband is worried, will she be able to bear children? So what are the things you will do? In a young girl whom you decide that you have to give cyclophosphamide, suppose she's got crescentic nephritis, you have to give cyclophosphamide. So what are the things you will do as a physician to
GnRH agonist can be done.
Yeah, so one could be GnRH agonist, so by which you can preserve the ovarian function of these people. So you should also talk about contraception in people where you're using these drugs. So it's very, very important to discuss contraception upfront on the very first day, and call the husband, and both the patient and the husband should talk about contraception. Extremely important in day-to-day clinical practice, because otherwise they will come again with a pregnancy while she is either on cyclophosphamide or bicafenylate mofetil, and you have to again induce abortion, and abortions are as bad as continuing pregnancy in these patients. They produce bad outcomes for both flare of lupus as well as so that's important, that you should avoid unplanned pregnancy. So very, very important that as a physician, contraception needs to be talked about, which many times in your busy clinics, you forget to do it. Second is, the husband is concerned, so you need to also take care of the concerns of the husband, that will she be able to bear children. So you should talk about how will you preserve ovarian function in these patients. So it could be a combination of GnRH. Anything else? One? Yeah, oocytes. Take oocytes. Ovarian. Okay. What else? We're taking the ovary and freezing it. And then taking it out. So all these are different methods by which you can preserve the fertility functions of the lady. Okay? So, and these must be talked about, and this is something which is again not taught or not hugely. So there is mention in the literature about it, you can find it out if you want to know it, but then you need to keep it always in mind that for young, lupus is a disease of the young. So these are concerns of the lupus, and as a physician it's very important for you to, suppose she is completed, pregnant, she is in remission. When would you allow them to become pregnant? She said she is very keen. The husband and wife say, no, they want to have children. So when would you allow them to have a child?
6 months.
Yeah, 6 months to a year. 6 months to a year in remission. And then what would you do then? She says, okay, she's in remission 6 months. She was on mycophenolate mofetil.
So MMF has to be stopped 6 weeks before the
6 to 3 months before. So I would stop, before planning, I would stop 3 months before. Usually I would stop 3 months before. Would change her to azathioprine. See that she remains in remission. When you change drugs, they may relapse. So it's very, very important to see that they remain. And I would probably again ask her to maybe continue on azathioprine for another 3 months, to see that they remain in remission, and she is. So 6 months, and then allow her to try pregnancy. So it's important that these are all planned, these are all done in that. And if you get these patients, so you have to spend some time on them. It's not like bhag jao yahan se nikal jao. So these patients require and personalized kind of a care. And you'll have to find also an obstetrician with whom you will be in direct touch managing these patients. So that you'll have to have an obstetrician who understands your language as well as is capable. So is in tune with the current management of lupus nephritis. Is willing to, this is a high risk pregnancy. So is willing to go along with the patient hand holding. So hand holding by a nephrologist as well as by an obstetrician is essential for making her desire that she wants to have a child and all that. So that's important. And it's important to allow it. In patients with CKD and all, if you have no absolute contraindications for it, having a child of their own is an important aspect in the life of a female. And I think it's very important for a physician to help them to do this or achieve this. Shouldn't be कि नहीं ये नहीं हो सकता, तुम्हारा खतरा बहुत ज़्यादा है. नहीं, खतरा है तो इसलिए तो आपके पास आए. So that's the way. So your overall plan should be that how can I help her? Obviously, if there is great risk, you should discuss that risk. There are many patients who would say no, they want pregnancy. Yesterday there was talk on pregnancy and dialysis, and I have had a patient who, despite my telling, said that no, she wants to. She was on dialysis and she said she wants to have pregnancy. And she had pregnancy and she wanted to continue it. I wanted to tell her this is about good 17, 18 years back. And she went ahead. So we had to give her dialysis. She continued. She had a pregnancy prematurely. The child had to be in the ICU for about 12 weeks or so. Spent a lot of money on the child itself in the intensive care unit in a private hospital and getting through daily dialysis. But that's what she wanted. So as a physician now, it is a difficult course. You have to go through, like you going up a Himalaya. Managing these patients are difficult, and you know that the outcomes may not be very good. You weren't very sure whether this would be successful, but her persistence that she wants to have it, and this is a dangerous course. You want to go on a very risky kind of a ride or something, and she says, "Come along with me." So many times you will have to make a choice: do you want to go along with it or not? So, as a physician, I think our aim is to help people do what they want to do and see that it remains safe for them as well, and you can help them tread that path. So that's important in these. So pregnancy is an important outcome in many patients because these patients are young. She's just married recently, and therefore this would be an issue in a long-term management of lupus in this patient. So that would be very, very important. Anything else? Any other questions you have?
If this patient presented after pregnancy, so if a patient has nephrotic syndrome, so does our differential change means in nephrotic syndrome during pregnancy?
No, nephrotic syndrome during pregnancy, if it presents, it depends on what time it presents. So presents in first trimester, second trimester, third trimester, and whether there is kidney dysfunction also, degree of proteinuria, hypertension as an associated feature. Because the most important determinant of outcomes of pregnancy is going to be either kidney dysfunction or hypertension. Blood pressure control, most important. These are the two parameters which are worse. If between kidney function, if there was a lady who has uncontrolled blood pressure, but kidney function is 1.2 or 1.5 or and there is mild proteinuria, I would not allow that patient to become pregnant. But if there is somebody with a creatinine of 2, blood pressure is very good controlled, proteinuria is mild to moderate, I'll say, okay, you can go ahead and maybe attempt pregnancy. Blood pressure is a very poor outcome measure for factor for outcomes of pregnancy. So somebody with uncontrolled blood pressure is not a good candidate for. So blood pressure would be very, very important. So management of blood pressure in that and kidney function, monitoring kidney function would be very, very important in this. The question is of doing a biopsy in pregnancy. Well, it depends on the condition. If you can postpone, if the treatment is not going to be aggressive, kidney function is okay, blood pressure is okay, proteinuria is mild to moderate, not increasing, I wouldn't do the biopsy at that point of time. But if kidney function is deteriorating and all, so I would want to know it. Then one will have to do a biopsy in this. And in first and second trimester, biopsy is not difficult. First trimester, one would try to avoid it because abortions might occur in these with the biopsy. So second and third trimester, the biopsy may be done in a sitting position if it is indicated. But by and large, I don't think in the current era you would usually treat these with an empirical therapy with steroids or something if these needed. The biopsies are, but in a patient with suspected crescentic or RPGN or something like that, we might have to either decide to terminate the pregnancy or depending on what stage of pregnancy you are. So those will determine basically what will. Anything else?
When do we say nephritic nephrotic syndrome?
Nephritic nephrotic will be when you have features of nephritic syndrome along with proteinuria of bladder. So in nephritis, usually you don't have heavy proteinuria. Usually non-nephrotic, 1.5 5 grams, 2 grams, less than nephrotic proteinuria. But if you have proteinuria going up to 4 or 5 grams, 6 grams, and then you have also features of hematuria and oliguria and all that, so hypertension at presentation, those will be features of nephritis, and then a nephrotic syndrome of that proteinuria, usually nephrotic. So those would be the patients. The usual pathologies for nephrotic syndrome would be something like uh, what was previously called LS2. If you read old books of LS1 and LS2 nephritis, but currently would be membranoproliferative glomerulonephritis. C3GN would be one thing which will present with nephrotic, and sometimes acute streptococcal glomerulonephritis, crescentic. GN can present with nephrotic proteinuria. Anybody? Anything else? You have any questions or anything? Okay. Thank you.